Welcome. We are live. Welcome. This time I am live streaming to both YouTube and Facebook. Actually, I should have done this beforehand. Sorry, I need to wipe off my camera. It'll go black for a second. Woo! There, that's better. So this is my first time also simulcasting to Facebook. Welcome, Facebook people. So I will say there's a caveat here. I did not do the necessary things to have my moderator who's moderating the YouTube comments also look for trolls on Facebook. Hopefully they don't know about this and won't appear, but if it gets too bad, we may need to stop the stream on Facebook, but hopefully that will not happen. All right, well, let's get started with questions. Mental health, well, it doesn't have to be mental health related. It could be just a general question if you have one. All righty, so Nerdbama Rich, thank you for the super chat. Nerdbama says, just added Buspar to Effexor. What dose is best? I'm assuming you're questioning the dose of Buspar to your Effexor. So let me show you something to consider when adding when someone is adding medications to medications that you're already taking. It's called, you should always be looking for drug-drug interactions. And you have to be careful when you're adding medications that all enhance serotonin so that you get a multiplier effect or an additive effect of the medications, because sometimes you can get, sometimes it could not be very good interactions. And here's one way to check. I am going to share my screen. And you will see my moderator, Daryl, in a minute. Okay, so here is this site, WebMD. This is, you can get general information about conditions, all kinds of things here. But you can also check drug-drug interactions. If you are taking more than one medication, this is an important thing for both your doctor to check, but also for you to check in the event that you go to another doctor and they don't know that you're taking some other medications. That's why it's always good to let them know. But anyway, if you go to drugs and supplements, interaction checker, you then enter in the medications that you're taking. So here we have Effexor. Can't type. That's one. All right, and then we're going to put in, what was the other one? Oh, Buspar. Oh, add. I didn't do the add. Okay, and then Effexor. So anyone can do this, Effexor XR. One interaction found. And it will rank these warnings as serious, moderate, minor, that kind of thing is usually the wording that we'll use. And here it says, potential for serious interaction, regular monitoring by your doctor is required, or alternate medication may be needed. So, because they both increase serotonin levels. Now, that doesn't mean you can't take these two together. I'm gonna stop sharing now, but I just wanted to show you this is something that anyone can check for any of the medications that they're taking to see if there's any kind of negative interactions. So I'm going to stop sharing and get back over here. The reason I wanted to show you that is because adding two medications that both increase serotonin can be okay, but then you have to be careful about the dosing. So if you are already on Effexor and then you add in the Buspar, your doctor probably wants to keep your dose of Buspar low because of what we just saw with the potential for a serious interaction between the two. I believe the maximum on Buspar, if you were taking Buspar all by itself, kind of an average dose might be 15 milligrams twice a day for 30 milligrams a day. Buspar is generally a more than once a day medication. I think the maximum might be 60 milligrams. I can't remember off the top of my head. I don't use Buspar a whole lot. But I do use it with some, and average for my patients tend to be about 30 milligrams a day, maybe 45. So all that to say, your doctor may want to keep your dose of Buspar low if it's been added to a decent dose of Effexor, with a decent dose of Effexor being 150 milligrams. The maximum for Effexor is 225. So if you're already on 225, you may not want to take more than 10 milligrams of Buspar twice a day. I believe there's also a 7.5. If that doesn't work for you, then it may be better to consider a different add-on medication that won't negatively interfere or interact with your Effexor. All right, thanks for that question. What else we got? Carla Saunders. Hey there, Dr. Tracy. Love all your videos. Have followed you for years. Thank you, Carla. Yes, I've been on here for years. So thanks for continuing to follow me. AAM, $5 super chat. Thanks so much for the super chat. Can you please talk about the effects of miscarriage, hormonal effects, not the loss itself, and perimenopause on a woman with pre-existing mental illness? So thanks for pointing out or making that distinction about that you're looking at the hormonal effects and not the effect of losing the baby, which is going to have its own effect on you. So we know that hormonal balance or hormone imbalance, if you will, or how your hormones are. I'm getting a slow start this morning. Sorry. Your hormone levels affect your mental health. If you have low hormone levels, people, and I'm thinking women now with estrogen and whatnot, you tend to skew toward depression with low estrogen and progesterone levels. Thus, women who are perimenopausal or in menopause can have trouble regulating their mood, as far as if you were already depressed or already had depression as a condition, your depression may be harder to treat now, or you may find that you were on medication for years and you were doing fine, and then now you're not quite doing so well, and you experience a dip despite your medicines not changing. That may call for an increase in your medication or an add-on medication to kind of bump you back up after that hormone dip. Another solution is to take hormone supplements if you can tolerate hormone supplements. Another part about, and I'll get to the miscarriage in a minute, another part about perimenopause or menopause affecting your mood or depression is the impact it can have on sleep. So with hot flashes and things, you can have trouble sleeping or have disrupted sleep. You can start, women in menopause or perimenopausal can start not sleeping as long as they previously did. And it might not necessarily be because you're waking up with hot flashes. It's just that your sleep cycle is just shorter, the amount of time you spend in sleep. And without the assistance of a sleep aid, you have trouble sleeping your usual amount of time. Sleep disruption or sleep deprivation can then also negatively impact your mood and can worsen your mood. So what would you do in that scenario is really taking care to try and keep your sleep consistent, whether that be taking something, a sleep aid, even if all your life you've never taken a sleep aid and now here you are, you need something, or doing other things in the sleep hygiene realm to try and promote better sleep for yourself. like blue light blocking glasses in the evenings, maybe eye covers so that everything is very dark for you, keeping your room very cool at night so that you can sleep better, like things like that, not exercising too close to bedtime and whatnot. So that's menopause, perimenopause, the lack of estrogen, progesterone. After a miscarriage, you have spikes in estrogen as part of the, as part of the change from going from carrying a child to delivering a child. So in a similar way that someone who carries a child to term or a baby to term can have dips in their mood, either via baby blues or be at risk of having a depressive episode. So from having postpartum depression, if you have a miscarriage, you are still vulnerable in that way to developing postpartum mood symptoms, and whether that be, again, a milder form of baby blues that can go away after a few days or so, to developing full-blown depressive symptoms or depressive syndrome. If you were previously had depression as a condition before pregnancy, you are unfortunately at greater risk of postpartum worsening of your depression. Or let's say, you were depressed 10 years ago and really have been fine up until now that you're pregnant or had a miscarriage. Just having a previous history of being depressed before increases your risk of having something happen postpartum. And in this case with the miscarriage, I'm still considering that to be postpartum because it really is. So short answer is having a miscarriage or delivering a child, whether it be early or at term, can increase your risk of a depressive episode, especially if you have previously had depression in the past. Thanks for that question. Hold on, unmute myself. Anna, dear Dr. Marks, I have a question about the line between mania and hypomania. I asked my doctor and he said that there's no clear line. So how should I know if an episode I'm going through is hypomania or full-blown mania? Thanks for that question. That's a great question. And it's from Facebook. Yay. Okay. Thanks to people watching on Facebook. So your doctor is right. There isn't a sharp line dividing mania from hypomania. It's on a spectrum of functionality or impairment. How dysfunctional are the symptoms making you? How much is it impairing you? The exception to that is psychosis. So if you have a psychotic episode during your mania, you're delusional, you start seeing things or hearing things that don't exist, like both of those are psychotic experiences. All of those are psychotic experiences. The delusional thinking, I think, tends to be more the common presentation with mania versus the hallucinations. And delusional thinking, even that can kind of be on a spectrum of grandiose thinking that's gone way too far. So you would be looking at thoughts that you have that just aren't plausible. So for example, someone may feel like, I want to run for president. Like, I think I can do this. Let me start networking with people so I can run for president. Well, that's plausible. It's not very probable, but it's plausible. Versus believing that there's a plot that's being going on, and people in this, there's some invisible sphere of people who are influencing us by the words that they say, and there's these certain words that you hear that mean this and that and the other. Like, that's kind of typically how a delusional thought process proceeds. There's like all these little nuances and things that just aren't realistic. If you become delusional or psychotic, that is definitely mania. In the absence of delusional or psychotic symptoms, then you're looking at how dysfunctional is it, or how much of a problem is it causing you. So someone with hypomania, it's still problematic behavior, or the symptoms are still problematic, but they still may be able to go to work. They may not be as productive at work, or maybe hyper productive, but they're not sleeping that well. So instead of, maybe going a couple of days without sleep, you're sleeping 3 hours instead of your usual 6 to 7. You are, with the rapid speech and the rapid thoughts, they may be moving fast in a way that is kind of getting in the way of your communication, but not so bad that, again, you're not able to communicate at all. An example of someone who may be hypomanic and still functional, like can go to work, take care of themselves, is someone who's up at 1 a.m. painting their door on the outside. I'm thinking of an example of someone up at 1 painting their outside door because they noticed the paint was chipping. And then by 3, they're wearing down, then they go to bed, they're up at 7 and they get ready and they go to work. They didn't sleep very well, but they actually don't feel the need to sleep, because that's one of the difference with mania and hypomania. Sleep issues is there isn't the need to sleep. You've got like your motor is running very fast, so you don't feel tired enough to go to sleep. Versus, say, a depressed person who has choppy sleep or poor sleep, you feel tired and you feel like you need to sleep, even though you may not be able to. So I was trying to think if there's another symptom that stands out in kind of the spectrum of mania to hypomania. And then also hypomania, you're looking at severity and intensity of symptoms. It's hard for someone who's fully manic to not end up in the hospital or completely, like, they may not, even if they don't go to the hospital, for them to, again, get in their car, go to work, talk to people, and not have people be like, something's not right with this person. Like, it's that, the behavior is that over the top with mania. Versus hypomania, someone might be in your presence and feel like, whoa, you had too much coffee, what's going on? You might be a little disorganized in your thinking, but you can still kind of pull it together and slide under the radar of detection that something's wrong with you if someone else is observing you. So those are a couple of clues, but it is kind of gray. It is kind of gray. Celeste Starr, your videos are amazing, very helpful. Thank you, Celeste. Thanks a lot. Appreciate that. And from the Dark Tomb, thank you for your insights and videos. You are so welcome. You are so welcome. Toria Williams, do you think a 7-year-old should be on ADHD medicine? It depends. That's the standard answer for stuff. So the short answer is yes, if they need it. So ADHD really starts in childhood. It is, recognizing, appreciating, and making space for adult ADHD is something that's relatively new. And new being, let's say, 10 to 15 years. It's not as though it didn't exist 10 to 15 years ago, but there's a lot of resistance, even say 20 years ago or 15 years ago, of appreciating that adults can continue to have significant symptoms in adulthood, and it wasn't something that just drops off after childhood. So all that to say, it really does start in childhood, even if the adult never got treated in childhood. So that said, typically the symptoms emerge or become noticeable or problematic when kids go to school. Now, that doesn't mean that that's exactly when it starts. You could have a 3-year-old child that you notice is very hyperactive and more hyperactive than your other kids. But the attention issues and things may not really become apparent until that child goes to school, which, age 5, maybe 4 if it's pre-K, and they have trouble listening. They have trouble controlling their impulses more than other kids, blurting things out, not being able to, being the class clown thing, and, getting into trouble, having discipline or appearing to be a discipline problem. Then you've got the child who's not necessarily all that hyperactive, but needs to be told things over and over, seems to just not really be understanding things, when it's not that they're not capable of understanding. It went in one ear, out the other, and they've got to hear it again. And if they're inhibited from asking the teacher, can you repeat that? Then they'll just sit there and not really get much out of what's going on in the classroom. So all those are kind of the signs that you can see of a child whose symptoms are significant enough to cause problems. As I was answering the question about the difference between hypomania and mania and those symptoms being on a spectrum, it's similar with ADHD. You can have a child who's mildly affected by ADHD such that maybe they read slower. Maybe they do have to be told things a couple of times or need someone to repeat something to them. But if you do that, they can just kind of slide by and do okay. Maybe it takes them longer to do some things. That doesn't mean that they don't have some deficits in their attention and their processing, but it's not enough to put them in the principal's office, not enough to make them fail their classes and things like that. So they just kind of go along with the group with these deficits, so to speak, that aren't impairing them enough. If you have a child, though, who has significant enough symptoms that they are ending up in the principal's office all the time, getting into trouble, you're getting notes that we can't keep your child in the class because they're doing this and that and the other, or your child isn't getting it. They need to be told a bunch of times stuff. And as a teacher, I don't have time to do that. Whatever it is. Sometimes medication may be what they need to be able to get through school, unless you're prepared to pull them out of school and homeschool or do some other kind of enter them into some other environment where they can learn differently, because our standard way of teaching in school just isn't set up well for people with ADHD. There's just not a lot of accommodations to be able to take people's needs into consideration when there's, a class of 35 kids. Now, I know there's, IEPs, individualized education plans, and all of that stuff. And some of those plans can be enough to pull your child through without them necessarily needing medication. It just depends on what where their weakest parts are. So the medication thing is really, it's not a definite for everyone. Medications have side effects, and some kids can take the medications and feel depressed. It changes their personality. They stop eating, get really thin, and all of that. And then some kids can take medication and it's like the lights turn on for them, and they are getting their work done, they're behaving, they're not distracted and all of that stuff. And they soar in a way that they wouldn't have had they just sat there and struggled all of their school years. I think that's sad to see that be the end point for someone who spent 12 years struggling and not getting very far. And then they take medication and they're like, whoa, where was this all my life? So it's a very individual decision. There's not a single right answer because medicines can have negative effects, but then medications can also make a huge difference for some. So it may just be the kind of thing that you try. But I wouldn't demonize medications because they really can make a huge difference in the quality of some people's lives. Thanks for that question. All right, the unpopular popular. Thank you so much for the super chat. I'm going to have to put my glasses on for this one. So, after losing my mother 2 years ago, I'm still grieving severely. Are there any grief disorders? When should I seek help? Okay, so I'm sorry for your loss, unpopular popular. Generally, there is a condition called complicated grief. The name's kind of changed over the years, but complicated grief disorder. And really what that is it's where, let me say it this way. There's an expected amount of grief that we expect to have. That's a normative reaction. And it's different for everyone in how they experience it. And we wouldn't consider that a psychiatric condition or depression. It's a grief response. When do you draw the line, or when do you look at grief as being something that's a little more than a normative experience? That's kind of your question here. It's been 2 years. One kind of ballpark measurement is symptoms lasting more than a year. And after that year, you still being in a place where there's little acceptance of the loss. So it's always going to be sad. You're always thinking about the person. You're always going to miss them, etc. But after a year, like, how painful is it still? Is it still like a wound that's so tender to the touch that, it's like there's been very little healing? Now, that said, some people can spend a year in denial, in various states of grief, and then the second year ends up being harder than the first year for them. Still, though, in that scenario, there's some movement in their acceptance level, how they view the loss and whatnot, that you could still kind of see that as part of their grief trajectory. But another sign that you should get professional help is when, after a year, now it's 2 years for you, if there's like little acceptance of the loss as a real loss, like the person, some people in this state may still live every day as though they just can't be in this present world without their loved one, or the person that they lost. It's like they still just cannot. They still can't internalize that they're without this person. They may fantasize about the person still being there and things like that. Like, that is a sign that you should get grief counseling, either with a therapist or grief support groups or something like that, to be able to better process the loss and be able to advance through the loss, advance as far as your own level of acceptance and healing. And so again, it doesn't mean that it won't be sad, but it shouldn't be so impactful that you're still having trouble getting, functioning and from day to day, because you're still, your whole mind, your thoughts are still very focused around this person and them not being there. So you might want to start with a grief group versus, although 2 years, I would say I do think it's, you should look at getting professional help to be able to process the loss better. All right. Actually, this is a good time for me to pause before we take another question. I want to do a little show and tell. So I'm not sure when I'm going to do another live stream. I was doing them. I did like 3 months in a row, and then I said I was done. Then I came back and said, okay, I'll do another one in April. But if you don't get an opportunity to ask me a question here, or or ask questions in my comments, and I don't see the question and all of that, another way that you can be able to have a similar or even better experience of being able to interact with me and answer and get questions asked is in my mental wellness community. It's called the Mental Wellness Space. And I want to show you what the back end of that looks like. So I'm going to share my screen again. And where am I? Home. Okay. So here we go. This is the Mental Wellness Space. I created this community. It's a community membership. Last year is when I launched it. And what we do in this community is we have weekly challenges. I also have 2 Zoom live streams a month, in addition to a workshop once a month that is not on Zoom. It's in a kind of like this format where I'm presenting, but people are still able to ask questions. That doesn't necessarily have to be about that workshop topic. So that's 3 opportunities to be able to come to me with questions about your situation or some, whatever it is that's on your mind to better understand something that you're going through. So let me show you what things look like. So I think of this as kind of an enhanced educational resource for you, in addition to being able to interface with other people who may be similarly situated. So we've got the home feed, the home tab. So these are, I made this pointer a different color so it's easy to see. So these are kind of the spaces in this community. I'll go through them really quickly with you. So the home feed here, we've got the, this is kind of like a Facebook feed as far as the way it looks. This is an example of a challenge. This month's challenge topic is self-care. So a weekly post on something to do regarding your self-care. And then this is also just general conversation. All right. So then we've got Journal Club. This is every Tuesday you get a post, which is an affirmation and reflection exercise that you can either read or listen to. And it's to help you with it's to help, I guess, improve your self-talk, give you the vocabulary and the wording to use to be able to infuse your mind with more positive self-talk to replace negative self-talk in various areas. So let me just show you as an example. So this is January's exercises. So I'll click on this one. It's called I Cultivate Harmony in My Family. And there's an audio that you can listen to if you don't feel like reading. This is the actual exercise. Then there's the reflection questions. And then there's also the journal pages that you can fill out if you're better at writing things down. So anyway, that you could use to fill out. So let me click on that. I'll show you what that looks like. I hope I'm still in this. Let's see what you're looking at here. No, it did not. So it did not go over. Okay, I'll show you that as a separate thing, but this is this also has a coloring page that goes with it. Then this is new, Real Food Recipe Center. So there are, each month I post recipes for these different categories here. Let's just look at the vegan ones. And so there's only a few here because we just started this. This is a new thing. If you click on this, chickpea and wheat salad, there's a demonstration here on how to make it. And then the ingredients, you could see, let me kind of make this go a little bit faster. This is the demonstration, as you can see. And if we scroll down, these are the ingredients, the instructions. If you click on this, it's a printable form of the recipe. Okay, that's that. Then there is the resource section. These are most of all the freebies that I've made and worksheets and things that I've made over the years that I've just kind of put in this section that you can easily access instead of scraping them off my website and finding all the different web pages where I have them. Then there is, I'll skip over this community help desk. And this journal club, there's a whole year's worth of content in this section. Then there's the live events, which is what I was referring to. That's similar to this YouTube live here. So twice a month, I'll do a Zoom Q&A. And if you can't miss it, if you can't make it, there you can go to the replay section. So these are the replays so far for this year. And so if you click on there, same setup in the same room, and Zoom now is doing summaries, which I was super impressed by. So that's a Q&A. And the workshop, same situation. These are the upcoming workshops. And if you miss it live, here's the replays. These are a little bit different because they are more, let me turn off the volume there. These are like slideshow style, so PowerPoint style. And I am screen sharing, trying to get in here. Here I am down in the corner. But anyway, I'm presenting information, taking more of a deep dive on whatever the topic is for that month. And you also get a handout of the slides. And then sometimes if there's resources that I may have talked about or someone may have asked about in the chat, I may post other stuff. So there is lots, if you were to join now, there is lots of content for you to go through because these are the replays for for 2024, but there's also all these replays from these workshops that I've done from 2023. So that is the community. And let me stop sharing and get back to you. That's the mentalwellnessspace.com. The monthly fee for joining is $24.99 with all that value of at least 3 lives a month and then the additional things. Or you could join for the annual subscription, which I believe is $249. 10, so you get 2 months free if you do it annually. So that's the Mental Wellness Space. Go check it out. And again, I think a more efficient and better way to be able to supplement what you're getting outside. If you're already in treatment, it is not. Let me clarify something though. It is not a treatment group. So I am not providing care. I'm not doing evaluations. It's nothing like that. It's more education and interfacing with other people in a community. All right, so that's my plug for the Mental Wellness Space. All right, let's get back to the question. So Lakeisha Allen, Doctor, thank you for your platform and engaging with your audience in real time. Your expertise is appreciated. You are welcome. Thank you. Yeah, I like the real time stuff too. Charles, I don't want to mispronounce your last name. Thank you for the super chat. Why does a person ask for feedback and then ignore all the suggestions and do what they want to do? Funny. That's a personality thing. Some people, they'll have their mind made up about what they want to do, but they still want to just know what people think about, what's your opinion on what I should do? I'm going to do this because this is what I'm comfortable doing, but I still just want to know what other people think about it. And if you tell me to do something that I was going to do anyway, then I have affirmation that what I'm doing is the right thing. If you disagree and tell me something differently, okay, it's still interesting to know what you thought, but this is what I plan to do. Like that's one scenario. It could also be as simple as the feedback that they get makes them uncomfortable and they just don't really want to do what it is the person suggested. And so they'll just go do what they were going to do. So it may not be that they're just, being arrogant. It may be that they're, inhibited from doing whatever it is because what you said was just a little beyond their comfort zone. There's lots of reasons why someone could ask for advice and ignore it. People who are very insecure often don't ask for advice because they don't want that attention to themselves or be held accountable or have people expecting them to do something. So, there's lots of things that could factor into why people ask for feedback and then don't really follow your feedback. And one more thing about that, keep in mind, asking for feedback doesn't automatically mean that someone's going to do what you said. They just may want to take that in consideration. Maybe next time they might do that. Okay, next. Wright says, can you explain personality disorder? All right, I'll try and do this in as succinct a way as I can. People write textbooks on personality disorders. We all have personalities. We also have temperaments. Kind of temperament is the way that it's your hard wiring and the way that we respond to the world, our tolerance level, and takes into account things like risk aversion or being more toward the anxious side versus being more laid back or disinhibited. All those things kind of play into someone's temperament, your hardwiring of how you behave and you think. Personalities is a little bit more than that, but still kind of takes that into account of your temperament and tends to develop over probably like the time of life of like late teens, early, maybe tweens through early adulthood is how your personality develops. And that personality development is influenced by genetics and your environment. So, and your early experiences. So things like trauma and things or early disruptions in your life can affect your personality development. Now, we all have personality traits, and there are, I forget how many personality types that there are. I want to say maybe like something like 9, but those would be the things like paranoid personality, avoidant personality, narcissistic personality, which we all hear a ton about, obsessive compulsive personality, schizoid, schizotypal. Like there's several personality disorders. And those but within those disorders are traits that we can all have, but just may not be to the extent that it's a disorder. So a disordered personality is one in which the way that you behave, think, and relate to people causes interpersonal problems. it causes problems with your how you relate to people, but it also can affect you personally. Like it can affect your level of contentment that you have in your life. So, I'm trying to think of an example. Uh, I, I, I don't want to go down the narcissism path here, but I know that's the kind of the easiest and most popular one to talk about. But looking at paranoid personality, no, histrionic. Let's take that one. Histrionic personality. With histrionic personality, people tend to be with histrionic personality to be very dramatic, and somewhat superficial with things. Now, I could be kind of over the top dramatic about stuff. Oh, you're a wonderful person. You're the greatest. And I say that to everybody. But it still may not cause me problems. I just might be looked at as a very gregarious person that people like to be around because I make them feel good with all this stuff I say. And so I might have some traits of histrionic personality type, but it's not necessarily a disorder for me. It would become a disorder when it gets in the way of my relationships with people and even how I feel about myself, because generally people with personality disorders have some degree of adjustment issues, primarily because of the way that the conflicts that they have with people, or some sense of loss of satisfaction in their own life because things just aren't working out the way they expect them to, because of their skewed view on how things should be. And that's part of their personality disorder. So that's a real kind of off the cuff, brief, just one segment of what it means to have a personality disorder. As I mentioned, there's different psychological constructs to personalities, and different ways that people analyze them. And there's whole textbooks about them and things like that, and different models of how to define a personality disorder. And so a little bit beyond, what I would talk about here in answering that question. But I hope that helps you get just a general sense of it's a personality disorder happens when the aspects of your personality interfere with how you relate to people, how you respond to the world, and how you feel internally about how you're relating to people. All right, Colleen, question from Facebook. Having stage 4 breast cancer has really put me in a slump. I'm sorry, Colleen. I take letrozole, which is anti-estrogen, 1 milligram Zoloft daily, Ativan as needed. I am scared. I'm assuming you mean Ativan, which is, unless it's a cancer medicine, Ativan that I'm not aware of, but Ativan is a benzodiazepine that is generally prescribed for anxiety, but it could be used for other reasons too. Letrozole, yes, is like a I guess you could kind of think of it as chemotherapy, but not in the traditional sense people think of as chemotherapy. But I'm aware of letrozole and some of the negative effects of it, both physically. I've seen some people who felt very like body aches and just not having a whole lot of vigor and stamina. But at any rate, you said you take 1 milligram of Zoloft. Oh no, maybe your estrogen's 1 milligram and then you take Zoloft daily. Okay, so I'm not sure what your question is, Colleen. I'm sorry you're dealing with the breast cancer. So depending on, so the Zoloft or an antidepressant can certainly help your mood and may be a very necessary thing for you. But I would also look at taking a very holistic approach to how you feel as well when it comes to your diet. And exercise is tolerated. You may not feel up to exercising, but getting moving, even if it is just on a small scale, it doesn't have to mean getting a trainer and going to the gym. It could be taking walks in the around your block, getting sun exposure, because low vitamin D levels can also negatively affect your mood and correlated with depression. It's not a cause of depression per se, but there's a correlation between the two of people with low estrogen, low vitamin D levels also being depressed. So you may not know, you may have had your vitamin D checked, but if you are, many people are vitamin D deficient and don't know it because some of the things that can cause it, darker skin, using sunscreen, being inside the house or in buildings a lot and not getting much exposure to natural sunlight can all decrease or deplete vitamin D levels. Low vitamin D levels can also make people also feel very achy and just not good. So all that to say, there may be little areas where you can kind of chip away at all these little areas of your life that if you can improve this and improve that and improve that, it can have a cumulative effect of making you feel better. So doing things that can enhance your sleep, getting fresh air or getting exercise, preferably kind of the general recommendations these days are 30 minutes of vigorous exercise 5 days a week for you to experience like the mental health benefits is what I'm talking about. There's also, heart healthy and all that. But as far as the mental health benefits, what would vigorous exercise look like? Breathing hard enough to where you can still talk but not be able to sing. So if you're walking and singing, you're not walking fast enough. So that's actually, the 30 minutes is moderate. I said vigorous, but moderate level or moderate intensity exercise, or 75 minutes. So that's 150 minutes a week, 30 minutes, 5 days a week, or 75 minutes a week of vigorous or greater intensity exercise. And that could be like running, but it's activity where it is harder to speak now because you're huffing and puffing so much. You may not be in the kind of shape to run, and running isn't good for everyone. Knees and all that stuff. So I'm just, kind of completing the thought on the exercise levels here. But I would approach how you feel from a multifactorial, holistic level of trying to tweak and improve multiple areas in your life, like your sleep, your diet, your exercise level, to be able to have all of those things come together to feel somewhat better, to have improvement. And then don't forget about the vitamin D, because I do think that can play a big factor too, without people realizing it, because they're just not necessarily checking it because they've got too many other things going on. And vitamin D can be supplemented. Of course, you should always check with your doctor, given that you've got medical issues, about any kinds of supplements or things that you add to your regimen. But if your vitamin D is low, that can be rectified fairly easily with sun exposure, or also with vitamin D supplementation. I hope you feel better. Okay, Jay. Wow, thank you for the super chat, Jay. Okay, look like you packed in a lot here, so let me see what you got. History of ADHD, PTSD, and TBI, which is traumatic brain injury. in and out of psych wards. Started modafinil and everything is gone. My thoughts and actions are now on a higher level. I searched. It seems like this is an extreme response, but in a positive way. Any thoughts on it? Yes. It's funny you mentioned this, Jay, because I just saw something go across my desk or my computer. It was either, I don't know if it was on X, formerly known as Twitter, or if it was just a news article that came in my inbox about modafinil not being the stimulant that people think it is. Modafinil is a wake promoting agent that's generally used for conditions like narcolepsy, but generally used for excessive daytime sleepiness to make people be more alert and awake. I have seen it used for people with ADHD. It's not recommended as a standard treatment for ADHD or an equivalent substitute for the stimulants. And that's probably because of where it acts in the brain. I can't think off the top of my head the mechanism of action for modafinil as far as where it works in relation to where the stimulants work. So the stimulants increase dopamine in areas of the prefrontal cortex that's involved in, things related to ADHD. Modafinil, if I had to guess, and R-modafinil is another one, it probably just works in by increasing wakefulness in a different way. So all that to say, I've prescribed it actually for people who were taking a medication and it made them sleepy or tired all day long. And then took modafinil and that perked them up. And so they were able to stay on the antidepressant. In this case, it was an antidepressant. So I don't have an explanation of why modafinil just kind of wiped everything out. I'd say, hey, if it works, good. I don't remember how long you said you've been taking it. Let me see what you started modafinil. So another possibility is that it's a placebo response. Now, I think that's a pretty dramatic, a robust placebo response to have kind of all of everything go away with this from a placebo response. A placebo response is where your body responds, or you have symptoms that resolve or something, but it's not because of the medication. It's just from the act of taking something that does not have the same therapeutic action. So let's just say, common thing is sugar pill. Take sugar pill, someone takes a sugar pill and they feel better, and someone takes an antidepressant and they feel better. Placebo responses are a regular part of medicine and life. I mean, when drugs are studied, there's a placebo arm, and of people who are getting a sham treatment, whatever that looks like for whatever they're comparing it to, whether that be a sugar pill or something else. And there will still be people in that placebo group who experience some level of improvement. And so to see that drug that's being tested is actually effective, it's measured against the improvement from the placebo group. So it still needs to be greater than the improvement from the placebo group. This may be too much in the weeds, so sorry I got down this hole, but to kind of pull myself out of it. So my point is that, depending on how long you've been taking this medication, maybe some of this could be a placebo response where we don't know why, but you've just had some level of improvement of your symptoms from this modafinil. And it also could be the modafinil is doing something in the area of stimulation and activity in the prefrontal cortex where a lot of the ADHD symptoms are generated from. And even though it's not seen as an adequate ADHD medication is working well enough for you. Because what's adequate? Adequate doesn't have to mean nothing. It does nothing. It just doesn't do enough to qualify as an ADHD primary treatment. So it could be that you just are in that category where it does something, and that something has been sufficient for you to improve your symptoms. And in terms of like everything going away, I don't know what everything is, but you said you had PTSD and traumatic brain injury. I think on the one hand, I think ADHD has become a disorder that in some ways, I got to tiptoe lightly with this, in some ways it seems ubiquitous in the sense that, many people will just say, oh, that was my ADHD. Well, but everyone doesn't have ADHD. But the people who do, for real, it really is far-reaching in what it can affect for you, not only attention-wise, working memory-wise, all of that stuff, but even in your emotional processing. And I think we are only recently starting to appreciate more of just how wide-reaching ADHD really is, as far as the different domains or dimensions that it affects a person. And so I would not be surprised if something that addresses your ADHD symptoms would also improve some of the emotional processing around the PTSD. Now, I'm not saying that, treat PTSD with stimulants, but I'm just saying that I guess it doesn't surprise me that if the modafinil was addressing that, if I've got the facts right here, that improving your ADHD, anything that improves your ADHD would also help the other conditions that you have and I'm not saying it necessarily treats your PTSD, but it might improve the way that you process the emotions around the traumatic event. That's a long rambling answer. Sorry. Timothy Doyle, where do you go to get tested for ADHD for an adult? So Timothy, thanks for that question. The most concrete answer to that question is psychologists are usually the ones that do formal testing for ADHD and any other kind of learning issues, learning disorders, things like that. And if you were someone who, like a student who was looking for accommodations, usually at the college level, some of those places will require that level of reporting. Like they won't just go from a doctor's note that you've got ADHD. They want to actually see the testing results. But not everyone requires that level of testing results. The diagnosis itself is based on a clinical interview of someone asking certain questions and you presenting certain symptoms that fall under the category of ADHD symptoms. So psychiatrists like me will diagnose via asking questions in an interview. There are some, they call them batteries, but tests or questionnaires that doctors can use to supplement that diagnosis. And there's lots of them out there. There's even ones you could probably find online, ADHD questionnaire that you could answer yourself. I actually don't use those because I just feel like it's too easy for someone who believes that they have ADHD to just say yes to everything. And I don't mean that necessarily in a negative way. I'm just saying I don't think it's all that useful. It can be, those questionnaires can be useful as far as giving more details about what you're experiencing and maybe putting into words what you're experiencing. But I also believe a good interviewer can extract that information from you with the questions that they ask as well. And that's the approach I take. I want to hear you tell me what you're experiencing, and I can figure out what that what that correlates to as far as on the symptoms list. So that's kind of, so the final answer, a formal answer is you can get psychological testing, especially if you could see a psychologist, get testing, especially if you're wanting something where they want to see evidence or proof or something written, like some written report. And usually that's more an educational setting, someone wanting some kind of accommodations or something. If as an adult, and it looked like an adult picture I saw there, but for an adult, if the real question is, how do I suspect I may have ADHD because I've been hearing a lot of stuff online. Yes, Timothy, you look like an adult. And I don't know, you may not even be asking for yourself. But if the question is, I've been hearing, I suspect I may have ADHD, how do I know? You could go to a psychiatrist and get evaluated. And that psychiatrist may or may not do testing. So because it's a clinical interview, just like if you were going, reporting symptoms of depression and wanted to know, do I have major depressive disorder or am I just in a funk right now? What's the difference? That could be answered by a clinician. Doesn't necessarily have to be a psychiatrist, but a clinician performing a clinical interview. And there's certain questions that we ask to get the information to be able to render a diagnosis. With ADHD, I said go see a psychiatrist because I don't know how many primary care doctors want to get involved in diagnosing, establishing that someone has ADHD. Although the exception to that is usually in kids, it may be the pediatrician who establishes the diagnosis. And they may use, I've seen this before, where they will give the parents a questionnaire thing for the teachers to fill out about how the child is performing in school and things like that. And they'll take that information and combine it with the interview and then give a diagnosis and prescribe medicine if indicated. All right, Matto thinks. Thank you for the super chat, Matto. What's your opinion on personality theories like MBTI and the Big Five, etc.? Make sure I see all of this. Is it valid to use them in conjunction with mental health awareness? Are some mental health issues more common among some personalities? Okay, leave this question up a little bit since it's got a few parts to it. So, Matto, I'm not familiar with MBTI. I can't think of what that means, but I know that there are several psychological constructs or models for personality theories. I don't keep up with them all because I just don't. That tends to be more probably in the realm of psychology and psychologists. But yeah, I'm familiar with the Big Five and all of that. So here's something though. Let me say this. So, I feel small saying this, but psychiatrists tend to rely more on the Diagnostic and Statistical Manual of Mental Disorders for diagnosis. I don't know if things have changed since I trained, but when I trained, that's what we used to even get board certified. We had to do an oral exam, and you pretty much just kind of had to memorize all those disorders so that you could answer all these questions. I don't think they do the orals anymore. So all that to say, the basis of the DSM model, not everyone agrees with it. Not everyone thinks it's the best model to use for personalities. I recognize that. That's why I say I feel small saying this, because even though there's these issues of, is that really the best model and all that, that's still what I rely upon. And I don't keep up with all the emerging other theories except to just kind of read about them from time to time, but I don't study them. Okay, so that's answer to part one of your question. Is it valid to use them in conjunction with mental health awareness? So, let me see. Here's how I would rephrase the question as far as how I'm going to answer this. And so another way, or what I interpret that to be, to say is I just had it and I lost it. How relevant is it to use these personality theories? How much should we be thinking about personality theories? So when it comes to mental health awareness, I think of mental health awareness as something that the end user, the consumer has, not the doctors have or the clinicians have. It's you as an individual having mental health awareness, you being attentive to your own mental health needs, and then us as a society. That's part of my shirt today. Mental health, it's my shirt. Mental health commands a seat at the table, because to me it's about time for mental health to get the attention that it needs. And I think we're getting there. I think we're finally getting there. 10 years ago, it's not something we want to talk about that much. And so anyway, that's not your question. So going back to this, is it valid to use these personality theories in conjunction with mental health awareness? What I think about when you ask with that question, I think, and this might not be your question, I think about people self-diagnosing and calling out other people, saying that you're a narcissist or you're a this and that and the other. And I don't think that's the application of mental health awareness. It's not about trying to figure out what someone's personality is. Now, if it's about understanding your own personality and how you can improve upon yourself and how you relate to people, then that's great. But that takes a lot of self-awareness, that takes a lot of introspection, and that's not for everyone's not there. So what I think it devolves into more often than not is finger pointing with other people of, you're just a this, that, and the other. And I think that's not only is a misapplication of the theories, because how do you know you're right? How do you know that somebody's got, that someone else is high on the neurotic scale? I mean, and why do you need to know that? But anyway, but if you want to recognize that you're high on the neurotic scale, okay, then what are you going to do about it is really the issue, more so than I know this and I'm just going to, speak it in the air a lot. So the short answer to, is it valid to use in conjunction with mental health awareness? I don't know how helpful it is to the average person to study and learn about the different personality theories. I think that's a little high level for just regular everyday application. Are some mental health issues more common among some personalities? They can be. So there's not this these two go together kind of thing. If somebody's got OCPD, then they're going to be depressed. But depression, there are some people, so some people who have a lot of conflicts because of their personality issues, can become depressed or struggle with depression. But that's kind of a reactionary kind of thing, as far as, reaction to your life circumstances, not, you not having with there being a lot of friction because of your personality, making your life hard. And then, you're not very happy with yourself, your life, with other people, lonely. You can socially isolate because you think the world is, everybody's this, that, and the other, and you don't want to be in it, whatever it is that the person's thinking. But there's not like this common pairing of this personality causes, with this personality, people typically have this. We see that more with some of the regular mental health conditions, like, autism spectrum. It's fairly common with people on the autism spectrum to also have ADHD. Those often go together. ADHD and anxiety can often go together. But yeah, as far as personality disorders, I think it's kind of the sky's the limit, because they're kind of two separate tracks. You've got your personality, and then you're still vulnerable to any of the other mental health conditions out there. All righty. Thank you, Matto. Take a sip of my coffee. All right. Kosaki, can you please make a couple of videos talking about schizoid personality disorder? Love your videos. Thank you, Kosaki. I have one on schizoid. Pretty sure. I have one on, I think I've done all of them except narcissistic personality disorder. That is the only one that I haven't done a video on. And that is because it's a very complicated personality disorder in my view, and I just don't feel like I could do it justice, or haven't been in the right headspace to make one to do it justice, so I haven't done it. I'm pretty sure though that I have done all the others, and that I have a personality disorder playlist. So schizoid, though, I will say just real quickly, falls into the according to the Diagnostic and Statistical Manual, not another model. The personality disorders are grouped by similarities. So there's the dramatic personalities. There is the odd or eccentric personalities. And let's see, odd and eccentric is one, dramatic, and I'm missing one of the categories. But schizoid falls into the odd eccentric. And with schizoid, people tend to be very isolated by design or choice. There's an aloofness there where the person is good being by themselves, and they're fine with that, which actually, that's not a bad state. It's sad to want connections, but be too afraid or too anxious for connections, and then therefore that causes a lot of distress for you. Versus the aloof person who's like, I don't need you. I'm good. Like, there's actually some, contentment in that. But it can still cause problems in other ways, because often you can't just be an island and live all to yourself. And that aloofness and things can cause conflicts when you're dealing with other people. But thanks for that suggestion. Anyway, I'll take a look and see to make sure. If I did not do schizoid, then I will, because I did want to cover the personality disorders. So thanks for that suggestion. Okay, Jack. Oak Jack. Do you have any favorite mental health related books? Let me think. No, because I don't read a lot of mental health related books. That sounds terrible, but otherwise I'd always be working. Like, that's work for me. Just like I don't watch doctor shows. I've never watched ER. I've seen some snippets. Chicago Med, like all those, Grey's Anatomy, like I just am not interested in medical shows. I like legal shows. My husband's a lawyer. He doesn't like legal shows. So similarly, like if I am not working, I want to read mysteries or thrillers. Like that's the kind of stuff I would read in my free time. If I were reading mental health books on my free time, then it's not free time. I'm still it's an extension of work. So the stuff that I read really are journals and journal articles and research. That's how I stay up on current news and what's trending and what's currently going on in psychiatry and other specialties. I keep up with some other stuff too. So journals are really the ways that, say, doctors or clinicians stay current. And I only got so much time in the day, so I'll read that stuff, but I don't really read like books. But I'll kind of keep that in the back of my head. I know there's something I have had that I've read that I've liked that would be I've got a couple of textbooks, actually personality disorder textbooks, but they're textbooks. They're not like for the general audience. But if I can think of something, I will let you know. All right. Forbidden. Can someone with ADHD can be an effective therapist? Sure. Forbidden. So the question is, if you have ADHD, can you be an effective therapist? And my answer is yes. I would not eliminate any career aspiration because you have ADHD. It's a matter of working around your weak spots, whatever those are, and they're not the same for everyone with ADHD. So some people have a strength in this, but when it comes to this other thing, it's not going to work. So example, okay, well, wait, before I go down that rabbit hole. So I'm assuming your issue or the question behind this question is, if you need to listen to people, can you effectively do that if you have ADHD and have trouble focusing? And I would say probably the way you will know if that would work for you is how you are when listening to, say, people you care about telling you about a problem. Because with ADHD, it's not a global inability to listen. If it's something you're interested in, it can hold your attention and you can actually hyper focus on that topic or whatever's being talked about. So you could, if therapy is something that really rings your bell and you like talking to people and being around people and hearing people reveal things about themselves, you could really get in a zone where you're really listening when people are talking. And you could actually be super effective that way because you are locked in and listening. And then you can spit back stuff that they said to them or help them reflect on stuff and, remember things that they said and all of that. Those are all good attributes to have as a therapist. But if you have ADHD to the extent that it kind of doesn't matter, it kind of doesn't matter what you're listening to. You seriously struggle with being distracted. I have a hard time believing that even a person who struggles with being distracted can't pay attention to anything. Like that's generally not how it works with ADHD. But still, if you just can't really settle down with any one particular interest, then yeah, probably being a therapist is not a good choice. You probably would even have trouble getting through the training for it because you can't lock in long enough to even learn what you need to learn. So that would be a clue that, okay, you're not going to cross the finish line here and maybe need to look for something else, maybe something where you have to work with your hands or something like that, just kind of as an example. Also, there's medication. Medication can help people with ADHD who are easily distracted despite being interested. So I'm interested in what this person's saying. Like this is my zone. I love this, but I'm still having trouble keeping my mind from wandering. There's medication. Could then take care of the problem. So it's not medication. You're not taking medication so you can be stellar and, so much better than everyone else, and I'm going to be superhuman. No, you're taking medication to fix a problem. Like, if you had high blood pressure, can you be a marathon or no? Can you, exert yourself and do all of this high intensity activity if you've got high blood pressure? Well, if you keep your blood pressure under control, you should be able to. And that means taking blood pressure medication to get it under control if you can't do it some other way. So you as long as you stay on your blood pressure medicine, then you should be able to do this, that, and the other. So this is a similar concept. That would be one workaround if you don't naturally click in and engage when talking to someone in a therapeutic setting because of your ADHD. Then a workaround would be taking medication to treat your ADHD so you can do your work. So yeah, that's my long answer to can someone with ADHD be a therapist? Dwayne, thank you for the super chat. They're offering off-script TMS for ADHD. Do you think it's worth it? Okay, off-script, off-label. So off-label means it's not that if something is off-label, a treatment is off-label, it's not FDA approved for that treatment indication. So you're using something that's been shown be good for something else, and it's approved for this purpose, but you're also going to use it for this purpose. So you're saying, so that's just an explanation for everybody else, Dwayne. So you're saying that someone is offering TMS for ADHD. Do I think it's worth it? I don't know. So let me think through this. So TMS is transcranial magnetic stimulation is TMS. And that is a procedure that uses magnetic waves similar to what you would get in a MRI machine to stimulate parts of the brain. And effectively what that's doing is similar to is making neuroplastic changes by changing wiring connections in the brain. So if you've watched my channel for any amount of time, you've probably seen that I like talking about interventions that affect neuroplasticity and brain wiring. And our standard antidepressants don't do that, but there's other things that do. Okay. So TMS came after electroconvulsive therapy, which does a similar thing. It has a similar mechanism of action, but it uses electrical currents rather than the magnetic. Okay, so that's TMS. TMS is indicated for or is approved for depression, usually treatment-resistant depression, and there's an OCD protocol as well. OCD being obsessive compulsive disorder. Those are the only two protocols I'm aware of. So now, then to use it for ADHD, I don't know. I think it depends. I think the answer is in the results. So usually when stuff is used off-label, it is because there has been enough usage in that area and demonstrated effectiveness to then justify using it, even though it's not approved for that. So whether I'm having a hard time conceptualizing how it would be effective, but if it's rewired, if they're doing it, so they have to change protocol, but if they're doing it, I guess, in a part of the brain that affects the prefrontal cortex and all that stuff, maybe. And so what I would want to see is reports of it being effective. Research, so these would either be case studies in the research or just outright research articles where they studied a group of people. And then it showed to improve ADHD symptoms. I'd be really curious to know if it does, how long the effects lasted. Because with standard TMS for depression, say, a typical cycle may be 5 days a week for 6 weeks. That's that's high maintenance. Going in every day, getting this treatment. And then, and unlike ECT, where you get anesthesia and you're pretty much wiped out the rest of the day, TMS, you can go in during your lunch hour, get your session, and then like go back to work kind of thing. Now, I don't know, some people may not feel that great afterwards, but in general, it doesn't wipe you out like ECT. So, for ADHD, if you had to do that 30 sessions, and let's say it was effective, like it really, you got focused. If that focus only lasted, and whatever else, because what would really be great is if it helped with executive functions, time management, planning, working memory, like all of those things aren't always adequately captured or treated by the medications. You can take stimulants, and still have trouble with organization, time management stuff. So if TMS incorporated these executive functions, now that's a game changer. But let's say it did, and the effect only lasted, a couple of months. I don't know about that. Like, that's not very long to then have to turn around, go back in there and do that 5-day-a-week thing. So that's another consideration when answering the question of, is this worth it? Like, what are you having to do to get the effect, and how long does the effect last? And I have not seen any research on that. Doesn't mean it's not out there. It just didn't flash across my, email inbox. And so now you've got me, you've got this on my radar. I'm going to look and see if there's some studies out there talking about this. Because I'd be very curious. I think it could be worth it if the effects lasted a long time, like, and you'll know I like talking about this, like psilocybin, mushrooms, still not FDA approved yet, but in the studies, 1 dose, and then there's another study with 2 doses, treating depression and having that effect so far from what I've seen in studies up to like 1.5 years. Now that's, now we're talking 1 or 2 pills and 1.5 years of improvement. So those would be the things I would look at to determine if it's worth it. What's the investment? What do you have to do for the treatment? And then how long does the effect last? Thanks for that question. LB, hello from Belgium. Love your channel. Thank you, LB. My late mother-in-law is from Belgium. A, I love your videos. Thank you. I showed your videos to my sister who is diagnosed with schizoaffective disorder, and she said they helped a lot. Yay. Wonderful. That's just music to my ears when I hear that someone learned a lot about themselves from my videos, or it helped in some way, because that's what I put them out there for. A, I was a child refugee back in the 90s. I'm 40 years old now. Okay. I feel like a lot of trauma is coming up right now. How do I cope? I feel like I've stopped developing at the age we escaped. Foggy life. Yes. So A, that's, the way you describe that is perfect, and is the way it can be with an early disruption in childhood that's traumatic, and there being a halting of emotional development from that point forward, or just it being a rougher development. Like you don't completely stop developing, so you're not like acting or emotionally at age 9 when you're 40, but you're still behind. Like, let's say something happened at from age 5 to 9. Now you're 40, you may be emotionally, like a teenager or early 20s or something, missing a huge chunk of normal, if you will, development. Okay, so anyway, back to your question. So how do you cope? I think with this with this level of trauma and dysfunction that it can cause, you really should be looking at professional help. Now, I know it's easier to say that. It's just easy to say that. Well, see a professional. Well, okay, but I got to say that. But still, because there's lots of trauma related information online these days, whether it be on YouTube, Instagram, books. There's some popular books out there written by people who are focusing on trauma and reparenting. Those may help. And so you could start with those kinds of books to see if those help you. One that stands out to me, someone asked me about a favorite book, although this isn't a favorite book, but I'm just, it's a book that has been very popular and helpful, is How to Do the Work by Nicole LePera. She focuses on trauma. She's not the only person who does. There's other people. So you could start with a book going from the self-help perspective and see what you get from that. Like, I don't know how much, how hands-on or how much that book helps you do stuff yourself. I would hope, that was the purpose of it, and How to Do the Work title. If that doesn't work, which it's not always going to work, and I say that not to be a negative Nancy, but to I guess reassure you that if it doesn't work, that's kind of normal, that you can't just do it on your own, because there takes a certain amount of being able to step outside of yourself and see your behavior or see your reactions, see your knee-jerk responses to things, and then be able to change. If we could all just do that, then we'd all be good. Like, there wouldn't, we wouldn't need professionals, but we wouldn't need anything. We could just kind of self-regulate and, change ourselves. And we can't, because you're in your head and you can't always argue with yourself, rationalize with yourself, or recognize even a maladaptive response to something. It's normal to you to just have this trigger and then this happen without a disruption in, wait, I'm responding to this thing as though I was 9 years old. I'm safe now. This is not the same kind of threat. Da 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 da. If you had professional help helping you recognize that stuff, you may get to where you can knee-jerk have these responses. You still may mess up or kind of do something reflexively, but then reflect on it, and then the next time not be so quick to have that reflex. Like, that's kind of the idea. You gain some information. So, because therapy doesn't necessarily have to mean, okay, now you're buying into years of, for the rest of your life, you're in therapy. No, you could gain some skills that then help you self-regulate, self-observe, correct yourself, etc. But that still takes a lot of work, journaling, reflecting, thinking, and all of that. There's also, so I would recommend, if you were going to go the professional route to get help, trauma-specific therapist. So someone who is trained in trauma treatment, and probably that's mostly what they do, because that's their thing, as opposed to they've got, 2 or 3 trauma patients. There are some other treatments like EMDR, eye movement desensitization reprocessing, that can help tone down like the hyper reaction that you have to things, if that's what you're experiencing. I don't know if that's what you're experiencing, because with trauma in childhood, called, we think more of CPTSD, complex PTSD, which is where you've got the trauma that's just infused into your development and your personality, and you go from there. And the way you respond to life and to people, and the things that trigger you, the things that derail you, are just kind of baked in. And that's different from the person who doesn't have that experience, walks outside the door, and someone shoots the person standing next to them and they're like traumatized. Like that's a different kind of trauma reaction that person has, which we would call PTSD. Not everybody exposed to trauma gets PTSD, by the way. It's not just you have trauma and then you've got PTSD. Not everyone develops it. But still, so with CPTSD, if that's what you have, I do think the professional help that comes along with that will be a little different than the standard, someone with PTSD getting these like specific treatments that last a subscribed period of time, like 4 to 6 months or something. So yeah, my final answer, it reminds me of that game show. Is that your final answer? My final answer is you could start with self-help, that's hard to say, self-help approaches with books and then following some people online. Not me, because I don't do trauma stuff online. And then if that's still insufficient, then looking for a trauma therapist, even if it's for a brief amount of treatment to help you kind of get back on track and then be able to take it from there. All righty. Let's see what we got here. Somehow it's harder for me to see with these light colors, but that's okay. So Scrantron Akon, thanks for the super chat. I appreciate it. Combat vet with severe PTSD. My wife wanted a break, and during our time apart, I wanted to be better so bad. You suggested bupropion and other things for PTSD. Celebrating 8 years tomorrow. Oh, wonderful. I suggested PTSD maybe in one of my videos, I'm assuming you're saying, but either way, oh, wonderful. Congratulations. Excellent. I'm glad that you're better. I'm sure it's still something that, you've got to manage. One of the things about PTSD, you get better, but there still can be residual things. So I think this is not for you, Scranton. This is just in general I'm talking about. I think with most of the psychiatric conditions, whether it be anxiety, I'm thinking more about anxiety now, PTSD, OCD, you're looking at a reduction and not a complete dissolution or just, complete resolution of your symptoms. I just don't think that's realistic. The realistic outlook on a realistic expectation of what treatment should do is drastically bring it down to where it's manageable and maybe even not very significant, but there still be some residual things there. So as an example, OCD. Let's say you can barely get out the door because you're checking knobs, or you've got to drive by a certain place a bunch of times before you can finally get to your destination. It takes you an hour to get somewhere that's 5 minutes away because you have to keep doing these things. Or your mind is caught up in all these, because some people's compulsions are in their mind, or mental compulsions. They're not necessarily checking and things. It could be counting. And so it takes you a long time to get stuff done because you're doing these counting or whatever in your head. A realistic expectation for improvement would be that you're no longer, maybe only go through a count cycle once and then you keep moving. Or maybe you only check knobs a couple times, then you get moving. It's no longer holding you back from getting to where you need to go. You're not spending an hour driving around. Excuse me. You still may have a fleeting thought of, let's say you're at a restaurant, and normally if you see someone, the wait staff coming to the table, and they've got the plate and they've got their thumb on the plate. Normally that would like freak you out and you wouldn't be able to eat it. Maybe you'd find an excuse to like get your food taken in a, or you might, taken away or to go box, or you might even ask them to bring you another one, whatever. But with treatment, whether that treatment be medication, therapy, the wait staff comes over, the thumb's on the plate, you have a twinge of, ugh, but you still can take the plate, and you might even eat around everything and leave a little bit of food left where that thumb was close to it. But you got through the evening, you ate the food, you didn't like curse at the wait staff for touching your plate, like all the other stuff you're not doing, but it still bothered you. And that's the residual leftover of what I'm talking about, versus you get treatment and you don't even think about it. You didn't even notice. I mean, maybe if that happened, great, good for you. But don't expect that. Like, things can still bother you. If it's anxiety, you can still feel a little apprehensive or anxious, but it doesn't overwhelm you, and it doesn't like dictate everything you do or control all of your thoughts and your movements and decisions. Like, that's the difference. It still occurs to you, but it's not overtaking your behavior and all your decisions. All right, I got off on a tangent on that one. Kush Pro, I love your videos. Thank you. Has ecstasy ever been used to treat mental health issues? Not yet. So, it's coming, hopefully. So, MDMA is, I think they're still in they're like the company that's developing it is developing it for PTSD. So it would be therapy assisted MDMA therapy assisted treatment, something like that. But it's all it's going to be wrapped up in one big treatment protocol of using it to guide therapy to treat PTSD specifically. So far that's where we are, and that's the closest to getting to market. Is it being studied for other conditions? Probably. I think I've seen a couple studies for it being studied for anxiety, generalized anxiety. I did a video on LSD for generalized anxiety. That's a different psychedelic. So a lot of these psychedelics, they're getting attention for certain things like psilocybin for depression, but psilocybin's also being studied for other conditions. No, you didn't mention a specific mental health issue, but it's been looked at for other conditions. MDMA, so far PTSD, but other conditions, I'm sure it's being studied for. So yeah, that's kind of the not semi-short answer to that, which is so ecstasy isn't being used yet, but it's close. And when it gets there, hopefully, probably, we'll see, this is end of April of 2024. If it's approved by the end of the summer, I don't know if the company will be like ready to go to market soon after that, or if it'll take them several months. So we could be looking at this by the end of 2024 or maybe early 2025. Thanks for your question. Okay, Glenn Howard. What are your recommendations for adults dealing with the trauma of being bullied as a child for having autistic traits? Diagnosed with PDD-NOS at age 5. PDD-NOS is pervasive developmental disorder not otherwise specified I don't think we call it. I'm this Glenn. This is for everyone else. I don't think we call it that anymore. I think it's all been captured under autism spectrum when the disorder when the new diagnostic manual came out in or version 5 came out in 2013, I think it was. So, but it's all kind of falling under the same thing, just like Asperger's is. I mean, it's all of those were old terminology, but still. So autism spectrum. How do I, what are my recommendations if you were bullied? Gosh. So I think this would fall under the category of trauma specific treatment. I mean, I guess it kind of depends on how it affected you. But, meaning, rather than it being just, well, of course, I was traumatized, but, do you have a lot of anxiety? Do you have social anxiety because of these experiences? With social anxiety being more than I'm uncomfortable around people. Social anxiety, when people have social anxiety, they have a predominance of worry and fretting about what people think about them. So they may avoid stuff because they assume that if they are in that situation, they're going to be shamed in some way, that people are going to be judging them negatively, and so on and so forth. So then they avoid these social things. It's also called social and performance anxiety. So it could be around, it could be the issue of being around people, but it could also, or interfacing with people you're not familiar with, or it could be having to do something in a performance mode, like speaking, giving a speech, or even just talking up in a meeting or in school. So all that to say, what kind of treatment you get depends on the effect that this would have had on you. Bullying could have affected your self-esteem and you struggle with depression. So you'd be looking at, what are we left with here? What are we working with here? Is it all trauma issues affecting, say, self-esteem and personality issues? Or is it you have a lot of anxiety, struggle with depression? I do think, depending on the severity, this also calls for professional help in the form of either a therapist. You could start with therapy, and again, look for a trauma-based therapist, or trauma-informed is another word people use. So trauma-informed therapist may be someone who does not, whose practice is not like 100% trauma. That's not all they do, but they've had lots of training in trauma-specific therapies, and they do trauma-specific therapies, even though they do other stuff as well. So seeing a trauma-informed therapist would probably be your best bet. And that is a term you could search for if you were to go to a site like Psychology Today. People list their practices there. I used to list my practice there when I was still seeing patients, new patients. And you can find out a lot about what kind of work people do. They even have they have profiles and they have websites, and you can search by your state, because this comes up a lot for me with people asking, would I be able to see them? I'm not seeing new patients, but even if I were, states require that clinicians have licenses in the state where the patient or client lives. So if you live in Montana, you would need a clinician, therapist, doctor who has a Montana license. So anyway, a place like Psychology Today, you can search in your state for a therapist who does trauma-informed therapy. If you have some other conditions resulting from these experiences, like depression or anxiety, that isn't adequately handled with therapy, then you could consider seeing someone, a psychiatrist, probably a psychiatrist over, say, your primary care doctor for medication. Now, some primary care doctors will treat uncomplicated depression and maybe even uncomplicated anxiety. So you could, if you don't have a psychiatrist, but you do have a primary care doctor, you could also go to them if you feel like you're struggling with feeling depressed. You don't have to diagnose yourself as having depression, okay? But if you are feeling depressed and not functioning to the capacity that you feel like you should, like that's all you need. You don't need to, I need to know, let me look up and see if I meet the criteria for depression. That's not your job to diagnose yourself before you can be good enough to go see the doctor, okay? You can go see the doctor because you suspect that maybe you're depressed, and see if your doctor will then prescribe something for you, which may make a world of difference in how you feel and give you an increased capacity to manage the self-esteem issues that came from the trauma or from the bullying. So that's kind of a different approach. Instead of therapy first, and if that's not enough, then medication. Sometimes if you have depression symptoms or anxiety that's just too overwhelming, you may not be able to address the therapy issues well enough because it's too much of the other conditions are too disruptive that you can't like adequately process and work through the other stuff. So starting with your primary care, if you don't have a psychiatrist, to see if you think you have depression or anxiety that's out of control, getting them to address that with medication, seeing what shakes out after that. Then if you still have a lot of negative self-talk, in being inhibited, not necessarily social anxiety, but being inhibited from doing stuff because you don't believe in yourself, or you don't think you're good enough, and you struggle with feeling good enough, or you don't volunteer for stuff. Let's say you're working, you don't put yourself out there for stuff and you miss out on opportunities. You still are employed, so it's not like it's obvious that this is causing huge problems, but it kind of is because you've missed out on opportunities because you're too inhibited, because you don't feel like you are good enough to even try. Like that kind of stuff, probably then that's the kind of thing that then a therapist could help you, kind of take the ball or take the baton and help you work out those things after the fact, or in concurrently with medication if you did need medication. All righty, got time for one more. Mike Penguin. I graduate with a bachelor. Thank you for the super chat, Mike. I graduate with a bachelor's in winter of 24. My goal, okay, let me put on my glasses. I keep taking them off because I can't see it with them on. All right. I graduate with a bachelor's in winter 24. My ultimate goal in LPC. Any advice for what type of jobs I should be looking for? Love your content. Thank you, Mike. And congratulations on being close to being an LPC. We need more of you. So thank you for the work that you're going to be doing. Let's see. Oh, so for everyone else though, LPC is licensed professional counselor. So that's a therapist. And usually, I know you said you're graduating with a bachelor's. Granted, I don't know all the details of LPC certification, but my understanding is a master's level, and maybe you're going to do that too. But let me just talk this out. To be an LPC, you get a bachelor's degree in something, and then a master's degree in something, and then there's these other requirements to become a licensed professional counselor. So you have to have people are first an APC, I think it's associate, maybe professional counselor, and you have to be supervised. So you have your work is supervised at some level. I don't know how detailed the supervision is, but and I've seen people where they'll go work somewhere where there's other LPCs who can then serve as supervisors, and they're working while they're like getting completing their requirements. I think they have to put in so many hours of clinical work that's supervised by someone, and then you qualify for probably another test. I don't know. Again, I don't know all of the details of LPC certification, but as far as what type of job, I would think, I don't know, because I don't know that you could actually work on your own to get your LPC, going and working in a clinic, a group practice even, where they're taking, I guess what would be an APC, sorry if I'm not right about that, but the point before the LPC, and get in your qualifications, get experience, not have to deal with trying to get your own clients. That's a whole big thing. And so joining a group practice where they're accepting people who are still looking to train and get certified, so that you're in and also it really helps to be in a group setting like that. Like, I'm in solo practice. It can get very lonely, working with no one to talk to. And I've been in a group practice before, and we'd have these lunch meetings and kind of talk through cases and things. And that was nice to have that, to have that, I can't think of the word I'm looking for, collegiality. I don't know, but to feel like you're part of a team. Even if you worked in a practice where there weren't team meetings because everyone's got their own patient loads, still just having other people around to bounce ideas off, I think, is very helpful and useful starting out before going completely on your own. One more thing, I don't know if there's probably work settings that welcome people still in training, getting their counseling, their certifications, like the VA. I mean, I don't know if the VA is taking employees, but like those kind of situations where you're being hired as an employee to work in this, in this setting where they give you the clients. You're not going and finding people. They give you the clients and you're just churning out work. It's kind of similar to like residency training for doctors. You work at a hospital and have outpatients, and you're not getting your own work. Everything's just kind of being dumped onto you, and you're churning out all this work, but you're gaining experience with that. That's what residency is there for you to just work, and like see a bunch of stuff and have things be old hat after a while because you've just done them hundreds of times. I was going to say thousands, but I don't know about that, but hundreds of times. So, another thing to look for, other than like a group practice who's willing to take you in, you'd still probably be an independent provider in that setup, but in some place, some kind of employment situation, I can't say what that would be, where you're hired as staff and you just churn out work for however many years to get your experience, your hours, your certification, and then decide how you want to work after that. All right. Thanks for all the great questions. So don't forget about my mental wellness space. If you want more sessions like this, it's even more intimate in the mental wellness space because it's Zoom. Now, if you feel inhibited about, being on Zoom and all that, you can turn your camera off. People do that, especially if they're like in a meeting, but they still want to like be a part of it. They'll join and turn off their camera. And then you don't have to like save up. You need to save up questions, for the lives, but there's enough of them that something comes up and you got a question about something's going on in your life, or even someone you're supporting and want some more information about how to help support something. It's a great way to get advanced education and then also interface with other people going through similar challenges. So I just want to look up one quick thing here. I want to make sure I didn't misspeak about something. Hold on. This is awkward. Okay. Yeah, I just wanted to confirm something. All right. So anyway, that's it. Thank you for coming. And until, if I don't see you in my mental wellness space, I will see you around. I'm not sure when I'm going to do another one, but I probably will pop in at some other point. All righty. Take care. Bye-bye.